Okay, Sasa, are you ready to get started?
Yes, I am.
Okay, perfect. Um, Welcome, everyone. This is our second meeting of the Public Health Committee's legislatively appointed safety work group for home health and other home and community-based provider types. We appreciate all of you coming. Sasa and I had a meeting immediately following Monday's meeting last week, just so that we could go over. I'm sorry, I'm Tracy Wodach, the president and CEO of the Connecticut Association for Healthcare at Home. So Sasa and I had a meeting last week after we got designated as the co-chairs to determine how we wanted to move forward with this work group, and also recognizing what both Senator Anwar and Representative McCarthy Vahey, the co-chairs of Public Health Committee, what they presented by going through the Public Act, first 6 sections of the Public Act, what they presented as our task, our what we need to accomplish. And I know that Representative McCarthy Vahey was trying to be as flexible as possible with us, and that the Public Act asks us to put our recommendations forward to the Public Health Committee on or before January 1 of 2025. She said that there's an awful lot that we may be reviewing and making recommendations forward, so we want to make sure that we take proper time and thought. So she did kind of indicate if we need to extend that time a little bit, we could, but I'm hoping that we can get much of our work done in the time that we have before January 1st. So I want to give Sasa just a couple of minutes to offer any comments, and then we'll jump into the agenda if you don't mind. And I do want to apologize under housekeeping. We just asked if you use your hand function, keep yourselves on mute, use your raise hand function. We thought there would be a chat function, but apparently Zoom has updated and they've removed the chat function. So, yep, I see your face, John. I know I was kind of surprised as well. So we do ask that you use the raise hand function, and then we'll try to call on you in order, and try not to miss anybody. So, Sasa.
Tracy, you nailed everything that we discussed last week. So I think we're good to go forward with the third item on our agenda.
Okay. So what we had sent out on the agenda, if you did not have time to review it, we thought that it made good sense. Sasa and I know that we want to have certain presentations moving forward so that we're all very familiar with what each type of provider or state agency or representative on this work group, how they intersect with home and community-based services. So then we could move forward with formal presentations so that we could all become more familiar with the various nuances and intersects. So what we came up with was we would like each of you on today's call, and we've tried to put a maximum of 3 minutes. You may not even need 1 minute, I don't know. But I know last week we did basic introductions. This week we're asking for a little bit more so it can help guide us to create further agendas. So we're asking you to get to know all of us a little bit better. Who are you representing on your work group, on this work group? How do you intersect currently with home health care? But please know that this work group also has hospice on it, and we will likely be talking about other types of home and community-based service providers. So how do you, within your role and who you represent, how do you intersect with home and community-based services? What are the barriers or challenges you currently see in keeping healthcare workers safe in the community? And then what do you see as the main goal of this working group? So I would like to hopefully go through each person on the group, and I will probably do it by roll call as to who's on the call. And I will begin to remind everybody that I'm the president and CEO of the Connecticut Association for Healthcare at Home. We are a nonprofit trade association who represents the licensed home health medical providers who provide services with medical orders, nursing, therapy, social work, home health aid, and we also represent licensed hospice providers who provide hospice care, end-of-life care in the community. There are many team members on a hospice team, nursing, as well as social work, spiritual support, bereavement, volunteers that go into homes, home health, hospice aides. And then we also represent non-medical home care. I know many of you may have some experience, personal experience, perhaps with a parent or a loved one there where you've needed to hire somebody to come into the home to help care for them more in a support way, non-medical, not medically or clinically driven by doctor's orders. So those are the members primarily of our association. And we work very closely with both Senator Anwar and Representative McCarthy Vahey this last legislative session on Senate Bill 1, particularly the first 6 sections. So I'm very interested in what others have to say regarding the safety work group and what you feel you'd like to get out of it. For us, we'd like to make sure that the bill that was passed, we have certain implementation requirements starting tomorrow, October 1st, with some very detailed requirements for information that we have to gather on all referrals that come to our home health providers. They have to ask certain questions about safety, about domestic abuse, sexual abuse in the home, about weapons that people may have, about a psych history, substance abuse history, violence history. We also are required to check the judicial branch website for criminal history, as well as the sex offender registry. So there's quite a few things that have gone in place. And we as an association have tried to put that all, synthesized it into being able to help our referral sources know what information we need. So hopefully they can give us what we need. So that's number 1 on October 1st. But January 1, if I were to give you our crystal ball and wish list today, it would be to have some type of a repository where the information is more easily accessible, whether it's the referral sources making the referrals or it's the providers accepting the referrals, have some type of a repository that where we can access that information. Reporting and training, try to have some common ground, try to have a common risk assessment that we can have, and certainly keep the worker, the staff member, as top priority for safety, and look to collaborate across the care continuum as well as all the stakeholders that are on this call. It's so important all that you do, that where you do cross over into the work that we need to provide in the community. And I think the biggest message I'd like to share with all is that we are not law enforcement. We are not safety experts. We are care experts in the community. So this is a challenge for us as well. We want to try to work with all of you to come up with some good solutions that are affordable, practical, and doable. So thank you very much, and I'll turn it over to Sasa.
Thanks, Tracy. Once again, my name is Sasa Harriet, and I am the president of Harriet Home Health Services. And, I'm here on this committee to ensure that I shed light on the current state of nursing and home health care in Connecticut. At Harriet Home Health Services, we treat patients regardless of their insurance status, location, and circumstance because we understand that it is our duty to provide care to everyone. Our clients include the people of Connecticut. We work with hospitals, insurance companies, and legislators to ensure that individuals get information that they can understand and trust. We've been trying to work with legislators to enact protections for our home health care team and others who brave the front line every day to provide quality health care to those who need it the most. We also want to make sure that we address the fundamental gaps and inequities in healthcare services, which especially affect those in communities that are rural and urban. For over a decade, Harriet Home Health Services has strived to redefine the perception of home health care, from providing wound care to victims of violence to spearheading vaccine rollouts and delivering healthcare services. Our team of dedicated and certified medical professionals are devoted to meeting individuals where they are to provide the highest level of care and ensure lasting health outcomes. What makes Harriet a leader in public health is our unwavering commitment to serving individuals in high-risk areas, such as the Promise Zone in North Hartford, where residents, many of whom are Black and Latino, face the cycle of violence, poverty, and unstable living conditions. Our team provide safety risk assessments to those in the community, in their homes, on stoops, or even in the street. We treat patients at high risk of danger, high risk of falling through the cracks, and when they're discharged from the hospital for the first time, they may lack the safety net to be able to manage their complex medical care, and we're there for that. We do this because we know that as healthcare professionals, our job is to treat and care for patients. However, our commitment does not protect us from the danger that awaits us behind the door, the other side of the door when we knock to take care of someone. There's a host of other concerns that personnel going into the home face. So our hazard vulnerability might include hurricanes, floods, ice storms, transportation issues, parking. We face direct, indirect violence, and those are just some situations in the home. Drugs, we may be inhaling cigarette smoke. There's fire hazards. There's a lot that personnel in the community face. When we're parked, we're getting towed. There's other issues. And then there's the concern for the direct violence when we are in the community for individuals who might not realize that what they're doing could potentially harm someone, and those who actually do. So we need to bridge some gaps between the traditional home health care, and I mean all that going home, not just home care. So bridge the gaps for traditional in-home services and specialized psychiatric support while addressing the significant delays and safety concerns posed by us in home health relying on external services to come in when we call for support in real time. We're asking to enhance the capabilities of home care personnel in being able to manage high-risk patients in the homes. We're looking to establish seamless communication and protocols between hospitals, the Department of Corrections, and other relevant agencies to facilitate the safe and efficient transition from one level of care to the other. We're also looking to optimize patient safety and well-being. That's our goal, to enhance operational efficiency and better resource allocation. We want to strengthen multidisciplinary collaboration with stakeholders which we believe will ultimately ensure the safety of personnel in the community. Thank you.
Thank you, Sasa.
Next, go ahead,
Yeah,
Tracy.
I think I actually have the list in front of me, so I know
Okay.
some people aren't on, but I'm going to move to other home health and then hospice providers, just in case there's additional comments that you want to make. And then from there, we'll move on to the other stakeholders on the work group. I don't believe I see Eric Smullen on the call today. Is that true? Okay, next I'm going to move to Terry Henning.
Thanks, Tracy. I appreciate it. I'm Terry Henning. I'm the Vice President of Government Affairs with Aveanna Healthcare. Aveanna is a licensed home healthcare agency providing continuous skilled nursing services to Connecticut children and adults with complex medical conditions in all counties in the state and a number of other states as well. Some of these are already said, so I'll try to abbreviate them. But in terms of the barriers and challenges we see in keeping healthcare workers safe in the field, we would include the unique challenges, the unique environment of in-home care, more specifically, the lack of a controlled environment like you find or more like you'd find at least in an institutional setting, and the unique challenges surrounding safety issues as a result. Another potential challenge or barrier could include costs or funding needs to effectively implement potential safety initiatives or technology-related solutions. And then finally, a constant barrier and challenge is the ongoing significant workforce challenges that already threaten access to care. In terms of the goals of the work group, again, some of these have been said. We hope, and it sounds like we've already started this work, that the work group will include education on topics such as the types and nature of in-home care, again, the unique home care environment and challenges, understanding of what technology or other solutions exist that could meaningfully improve caregiver safety. A related goal, I hope we have the opportunity to engage with law enforcement and technology platforms to discuss and consider the feasibility and effectiveness of potential safety devices or work group includes discussion and evaluation of cost and funding needs to support potential caregiver safety proposals. And then finally, I'll end where Tracy started. We hope this group's work includes some discussion, evaluation of the new requirements and implementation from SB1, including things like the new intake and disclosure requirements, potential challenges in obtaining certain information, providers' abilities to identify things like electrical hazards, and of course, potentially whether any of the new rules have any unintended negative consequences in terms of impact on access to care. But thank you so much. We are so appreciative of being able to participate in these conversations and in this really critical issue. Thanks.
Thank you, Terry. Jen LeDuc.
Hi, everybody. I am Jen LeDuc. I am the Director of Quality and Operations for Day Kimball Healthcare at Home. We are a Medicare certified agency accredited by the Joint Commission, and we serve both home health and hospice patients in our community, which consists of the 17 towns in northeastern Connecticut. Some of the challenges that I see here in the quiet corner as they pertain to my workforce here is, if we're talking about safety, we're talking about access to emergency response. We have very rural environments here. We don't have a huge population density, so our emergency responders are very limited. And our staff, if they're trying to get help from somebody, it's going to take a significant amount of time before somebody comes to help them if they need that. And that is something that's very scary to me. Recently I did mention the other day, we had an alarm go off here in our building, and it took over 3 hours for the police to get here. The alarm did sound after hours, and it, just kind of spoke to what we deal with here in the quiet corner. And some of it is we've normalized some of that because it's the way it's always been here. So it's for lack of a better term. Also, when we're talking about delayed emergency response, connectivity to the internet and to response systems is also a challenge. On any given day, staff are not able to log into their devices because they have no connectivity. So finding devices that are going to be reliable 100% of the time is going to be challenging for us. Of course, we have significant workforce challenges here as well. A lot of our prospective employees will go over the line to Rhode Island or Massachusetts, or even out to Hartford. There's limited workforce here. So the workers we have, they're juggling a lot. And again, going into these uncontrolled environments. And it's hard because I don't think my agency is part of a hospital system. And every single day when I'm talking with people from the hospital, they will make suggestions. Well, can you just do this? Can you just do that? But they don't really understand these are people's homes that we're going into. Everybody lives in different, they all live a different way. And it can be very challenging. You can't apply all these rules to the home environment necessarily. And then there's the lack of disclosure when we are receiving referrals. We're not always given the proper information. Sometimes I do feel that information is intentionally withheld, whether that's right or wrong. I know that happens. And we discover these things as we are trying to vet out care or when we're actually in the home and all of a sudden these things are unfolding right in front of us. So I would like something to be done to hold our referral sources accountable for giving us the correct and accurate information so we can be safe when we're going out there. And then finally, the cost. I think whatever we do, we have to be very careful that it's not cost prohibitive. Agencies, my agency, we're not for profit and we're not looking to make a ton of money from the care we're providing. We are looking to be there to care for the patients in our community. And every year it gets harder and harder to do that. There's more and more thrust upon us in terms of cost and requirements. So that is what I'm hoping for, that we can come to a place that is, we are definitely upholding our promise to keep our workers safe, but also doing it in a realistic and pragmatic way. And thank you, everybody.
Thank you, Jen.
Thank
Chris Pankratz.
Thank you. I'm Chris Pankratz, CEO and principal of Masters in Home Care. We're a Connecticut licensed and certified, Medicare certified home health care agency. Again, as those before me have stated, our core competency is really delivering high quality, personalized medical care and support to patients in the comfort of their own homes. And as nice as that sounds, there are significant challenges from a security aspect, as those before have mentioned me, not to regurgitate all of these, but we're operating in an uncontrolled environment. As Sasa indicated, you never know who's behind that door. You never know what's going on in that particular location. We see patients in a variety of settings, and our staff are somewhat isolated. They're going out by themselves. As Jen indicated too, there's a lack of detailed referral information. We really need to have a complete picture of who we're sending a staff member out by themselves potentially to go care and provide their professional services to. On top of that, you've got, again, the travel risks, whether it's, as been mentioned, parking, being towed, accidents, traveling between locations. And then we've got staffing shortages, the mental and emotional toll that it takes servicing these patients, and that could be a variety of stressors. They're operating in high stress environments to begin with. Now we've got potential safety risks, and just the emotional toll of caring for seriously ill or difficult patients. So I think, my primary motivation for serving on this group is really to collaborate with each of you to achieve, the goal of prioritizing safety of our workforce. And I think that we have an opportunity here to develop tools and best practices that can really have an impact across the state. So even though service delivery is inherently individualized and does vary by region, the intent of this legislation is to try to establish a uniform statewide system of screening and security measures to protect our staff and the patients. So from my perspective, we've got 3 challenges to do that. First, we're struggling to efficiently access the complete patient information and data that's required by us. So ideally, we would have some sort of system that integrates all this relevant safety data, including from many of the agencies and departments that are represented here today, so that agencies can have a comprehensive view of safety risks before we send the clinician out to do a visit. Second, we need a consistent measure and method for measuring risk. If we had the opportunity to engage experts in risk stratification to standardize some sort of high-level risk assessment across provider types, it would help address what I really see and what we're experiencing as the overwhelming task of interpreting data only accessible through public judicial systems. So this is well outside, as others have said, outside of our area of expertise. As Tracy said, our expertise is providing care in the home. That's what we're really good at, not interpreting risk. So I think this group is ideal platform for tackling really these challenges. And the third and last one, as Jen had mentioned, was making sure that funding is included. We're operating in a very tight environment to begin with in many different aspects. And agencies aren't making huge profit margins off this business. So we need to make sure that if we're going to survive and remain viable to see patients in our communities, we need to make sure that whatever solutions we come with are properly funded. So I think, really the primary objective here is to identify these best practice tools and resources that for home-based care communities, so we can really address these safety challenges facing our industry. Thank you.
Thanks, Chris. Okay, I'm going to move on to hospice now and ask Barbara Pierce to speak.
Thank you, Tracy. I'll be brief because poor Tracy's heard me testify many times before, but I think we know the challenges, and I think people on this call know, I'm not sure the public knows, how much of the time when people call hospice is urgent, and getting care there urgently is important if you're going to get it there at all. But I think the other point about end of life that may be slightly different is we don't want to end up in a situation where what we do makes someone volatile who wasn't volatile before. So when you start bringing people in from other states or countries or whatever, you can't check all those backgrounds, and you can't check them, it seems to me, in some cases, without permission from the people you're checking. And what we find is people are the most volatile when there's a delay in our services, and what's going to cause a delay in our services are more checks. So what I don't want us to do is put in well-intentioned rules that end up making people no more safe and a lot slower to respond. The point about being nonprofit and having funding attached to it is obviously important as well. So I think we all know, the challenge we face, and I'm not sure, and I know we all agree, we want to keep our nurses safe, but I'm not sure that there's any one thing we can do that's going to work for everybody without having what they call unintended consequences. So I would urge the group to be careful of doing something that turns out to be bad in the name of trying to do something that's good. Thank you.
Thank you. And Barbara, just remind everybody your role and agency.
Oh, sorry. I'm the CEO of Connecticut Hospice, as you can see in my background. So, and if anybody is near a TV, we're going to be featured on a segment about the hospice industry for Jimmy Carter's 100th birthday on the CBS National News tonight at 6:30. So there's
Nora
my
O'Donnell. Yep. Okay, and we have a new member to the work group, Lauren Nadeau. She is replacing Kathleen Chacon, who was on the list and not able to participate. So Lauren, would you like to introduce yourself and say a few things?
Sure, thank you. So my name is Lauren Nadeau, and I'm the clinical manager of hospice services with Yale New Haven Health at Home Hospice. We serve pediatrics through geriatrics across various settings. And I'm very excited to be a part of this group and hoping to collaborate about maximizing clinician and patient safety. I think Barbara brought up a great point that at end of life, there are a lot of different people who can come into play, a lot of different emotions. So also, it's not just clinician safety. Some of the people who may come in the home may pose risks as well to the patients. So maximizing patient safety across the settings. And we know that safety risks can happen anywhere. My clinicians do serve certain communities that do have much higher rates of violence related to gang violence, drug violence, gun violence. So I'm excited to be a part of this to see how we can help keep our clinicians safe while serving these communities that sometimes have higher risks, and being able to access technology that keeps our clinicians safe and that will work across all settings. I think Jim brought up a great point. Sometimes the clinicians are in settings where we don't have good accessibility. So finding something that works for everyone. And then I'd like to see that safety information being easily accessible across the state and to different agencies. So happy to be here and thank you for having me.
Thank you, Lauren. Sasa, do you want to continue by the list or would you like me to? I don't know if you saw the list in your email.
I'm just going by my screen. So next for me would be Sarah Gadsby. Is that okay?
Yep, that's fine.
Hi, Sarah.
Good afternoon, Sarah Gadsby. I'm the CEO for River Valley Services, which is under the Department of Mental Health and Addiction. I'm here as representing mobile response provider. We interface, as far as mobile response goes, we are obviously available to home healthcare agencies if they need further psychiatric evaluation. We interface, a lot of the services out of River Valley is outpatient, and we have an ACT team, CSP, Young Adult Services, all really outpatient level of care.
I'm sorry, Sarah, to interrupt, but can you explain ACT so that people know what it is?
Yeah, ACT is assertive community treatment. It's an evidence-based approach to serving individuals that struggle with traditional outpatient services. They may not be fully engaged, may be struggling really with a very serious mental illness and needs additional support. The team is available 7 days a week. The CSP team, I would say, is like a step up from a ACT team. The person may be more independent, but a lot of these teams, we interface right now with 7 home health agencies throughout. We have nurses embedded in the multidisciplinary teams. They are usually the contact for the home health agencies that we work with. The barriers and the challenges, I think it's everybody has really kind of spoke to the main pieces, which is the unpredictable environment going into high crime areas. The unpredictable environment is not always the person who's behind the door, but the neighborhoods that our teams and home health agencies are working in. And then the funding piece, and really after doing a risk assessment, and if we know that there's a level of risk, having 2 staff that can be available to be able to really support each other in the event that something could happen. And then I think one of the other barriers and challenges to keeping workers safe in the field is substance use. Substance use is hard to predict behavior when somebody is highly under the influence. So the main goal for me being on the work group is really trying to support a systematic approach to decrease the risk to healthcare workers in the field. Just listening to some of the other providers talking, the risk assessment is really I think a key piece in being able to be proactive and support individual safety. I'm happy to be here. Thank you.
Thanks, Sarah. Next, I have Stephen Magro from 1199.
Thank you, Sasa. Yes, Stephen Magro. I am the Policy and Research Director for 1199. We are a healthcare workers union. We represent over 11,000 workers providing services under the home and community-based waivers. I've heard so many people articulate so well the issues that home care workers face. I don't want to repeat them. I'll just mention a few sort of unique things from our perspective. One is the decentralization of the system, which makes accountability difficult and puts home care workers at great risk. There is an attendant sort of lack of a collective public health policy around this work. I think I alluded to it in the last meeting when we were trying to get basic PPE during the height of the pandemic mailed to these workers, and there were objections based on the fact that the consumer should be the one to direct whether they wanted to have PPE for their caregiver or not. This was a serious argument that was made, and it took a very long time to overcome that objection. So an almost anti-public health view of this work. We greatly respect the autonomy and integrity of the consumers and their need to have control over their own lives and their own health, but it can also be taken to, I think, unproductive levels that are really at cross purposes with the charge of this committee. So those are serious concerns we have that are, I guess, distinct from everything else that I've heard. And I'll just stress that many of the reasons for this, the willingness, I think, to tolerate this and the deprofessionalization of some of this work does relate to the fact that the workforce is overwhelmingly Black, brown, and working class white people, disproportionately immigrant, many working poor, and there is a sense, spoken or unspoken, that there's an endless stream of folks who can do this work. So there is just that much less care and concern given to their overall health and their overall needs and experience. And it's our job as a labor union to remedy that to the degree possible and to advocate with our membership, to engage our membership, to fight for their rights in the workplace. And we'll do that very vigorously. But I do appreciate the comments that I've heard before, which I would second. And I'll let the clock go out on this. I will say that I do have a standing meeting at 3 on Mondays, so this meeting is a little tricky for me to get to, so I may be leaving a little bit early, but I do thank you for the opportunity to speak here.
Thanks, Stephen. Thank you. Next, I see John Brady. John?
Yeah, hi, everybody. John Brady here. I am a registered nurse. I am the vice president of AFT Connecticut, and we're a union. About 34,000 members in healthcare, education, and public service. About 8,000 of those are in healthcare. And although the majority are concentrated in hospitals, they're also in clinics and in visiting nurse agencies. So I agree with a lot of the things people have said about the barriers. I think one thing that hasn't been mentioned that I will mention is that many times the threats to workers becomes normalized. and this is true both in hospitals and in home care, they just get so used to physical abuse, to verbal abuse, that it's in thankfully most of the time it doesn't result in a tragic incident, but every once in a while it does. And I think that's one of the things that we have to we have to keep considered too, and how we get the workers to also speak up when it's like somebody took a swing at them but missed. Like that's next time they're gonna get hit. I think the goal that we've had a lot of people state the goals, and basically it's to make it safer both for the workers in the field and for the patients and the families. But there's another goal too, and that I think ties into the recruitment and retention of workers, especially when you get into like the RN ranks or the LPN ranks. There's a limited supply of workers, and people will go and find other work if it's too dangerous to do it. I mean, it's only logical. So there is a second goal to this besides making it safer for people, and that is that. And I'll close, if I can, with one story. I saw Senator Martha Marks this weekend, and she told me that at the event we were at, she was going to have to leave that. It was a morning event, and then she was going to have to go to work. She is a visiting nurse. And she said that she had one of her charts for that day. It was the first time that it had a flag on it, had a red flag, and it was in red on the chart saying this person is somebody that has a history of, and she didn't go into details, but so that you should be alerted that there's a potential for a problem here. So, that's great to see that when we pass legislation, something actually happens that's good out of it, because at least she was alerted, at least in that one case. So I think that's it. Thank you.
Thank you. Thanks, John. Next, I see Bothwell.
Hi, good afternoon. I'm David Bothwell. I am the legal counsel and legislative liaison at the Connecticut Board of Pardons and Paroles. And here at the board of Paroles' job is to balance risk with rehabilitation in making decisions on the release of offenders, incarcerated offenders, back into the community. And I think the challenges that the board has is that number one is assessing risk is not an exact science. The board members use risk assessment tools. They use a structured decision framework in their decision making. But the bottom line is that there's always going to be some level of risk in the decisions that they make. I think one of the other challenges that that's come to the board has been facing more recently is that there have been a number of recent federal court decisions in the last few years that have really, from a constitutional perspective, have limited our ability to impose certain conditions on offenders based on constitutional provisions. And that's particularly in the area of sex-based crimes and sex-based offenders. But the goal of the board, and I think our purpose for being here, is the goal that we have every day in making the decisions that are made, and that's community safety for all home healthcare workers, as well as every other individual that's a member of the community here in Connecticut. Is our number one goal is public safety. Thank you.
David, can you just address a little bit about what the intersect that you have with our providers in the community? Are you aware?
No, I don't necessarily think that we have like a direct intersect. I think, we intersect with all aspects of the community, in that we try to make decisions based on risk and balance that risk with the rehabilitation, and hopefully making the correct decisions, but we don't, unless there is a particular case in which there is a victim that has worked in the home healthcare industry, or someone who has, made known concerns, then we don't have really a direct intersect. I think we have an overall job to protect every member of the community. And I think I can tell you for sure that that's the board's number one goal in making every decision that they make. Is public safety is the number one concern that they have.
Okay, so if someone is being referred to, if they're coming out into the community and they're being referred to home health for services, there's no communication there currently, or there is on refer? I'm just,
I think we have to separate is what the Board of Pardons and Paroles does is it makes the decisions on release. Right? It makes those risk-based decisions on release. I believe Rihanna Gingras is here, and she is the Director of Parole and Community Services, which is we work in conjunction with, but individuals that are released are under the jurisdiction of the Board of Pardons and Paroles. That means the Board of Pardons and Paroles makes the decision to release and then imposes conditions as part of that release. Parole and Community Services is the monitoring and the supervision of those individuals while they are out in the community. And in terms of, if there's complaints or issues with them while out in the community, it would be probably Parole and Community Services who are interacting with, the healthcare workers. If there is a fear or a concern about their safety, it would be reaching out to the direct supervising parole officer. And if there was an issue that warranted a violation, then the case would come back to the board to sort of adjudicate that violation and determine whether or not there was a need for revoking the parole status and reincarceration.
Thank you.
Thanks,
My pleasure.
Dave. Thank you. I see Rihanna is next. Hi, Rihanna.
Good afternoon, everyone. Rihanna Gingras. I am here as a representative for the Department of Correction, specifically the Division for Parole and Community Services. As David had indicated, we would have more of an intersect than the Board of Pardons and Paroles for sure. The way that we play a role is that we supervise the persons, some of the persons that are out on supervision with under DOC or under the jurisdiction of the Board of Pardons and Paroles. So we would have more of a direct connect. The barriers or challenges that I have seen and that I think play a huge role in this meeting, as some have said, it's about the communication. Some of it will be touched on in this public act, but being able to communicate, I think there is a little bit of a separation at times between healthcare providers and the department. And for kind of the patient-client privilege, when it comes down to certain health information, I think there's just a separation of sorts, which one of the goals would be to try to overcome that and try to fix some of that by communicating a little bit differently. The other barriers or communication I've heard people talk about is folks going out individually. So perhaps there's usually strength in numbers. So if there was a way to send out to a home, because the healthcare providers are going out and there's one, maybe two residents in the homes, at least in some of the apartments. And then of course, if they're going into a residential house, there could potentially be more folks in the home. So so that was a couple of things that I was thinking about. A goal is definitely just to listen to the concerns and try to identify ways that we can improve within parole and DOC overall. I heard mention of referral and the information that providers are getting when the patient is being referred. And so I do think that that's something that we can improve on potentially. So that's something that I would take back to our agency. So I don't know if anybody has any other questions or if that addressed what was said by David Bothwell. That's all I really have.
Thanks, Rihanna. I see Karen.
Hi there, I'm Karen Buckley. I'm the Vice President of Advocacy for the Connecticut Hospital Association. The intersection with home health care is kind of multifaceted for us. Certainly, some of our hospitals actually have home care affiliates, but perhaps most importantly for every hospital is that we have patients who need home health care. Due to current staffing and other issues, we already know that there are delays in people getting the care that they need in the post-acute care setting, in particular homes. That's just a reality, not a criticism, just so we're clear that we know that there are a limited number of people out there and that there are delays in that happening, and that does impact consumers. When we look at barriers and challenges in keeping workers safe, I think, you all have done an excellent job enumerating those. I don't really have any additional ones to add. I think one of the challenges we want to keep in mind is the balance of making sure that people can and consumers can in fact continue to receive care in the home. I think someone on the last call noted that there's quite a bit of a movement to move care to the home setting as much as possible. And kind of with that comes with barriers and challenges and things that we need to keep in mind. But as consumers look for that more, we have to kind of look at what are the challenges in providing that care and doing it in a safe way, of course, but also doing it in a timely way. For those who can't get home care, they end up back in hospitals, which is not the appropriate setting for them in more cases. Or if there's a delay in home care getting out for whatever reason, usually lack of staff, that does bring along challenges of readmission to hospitals and other challenges for the consumers themselves. And so, some challenges are more difficult than others. We certainly saw that during COVID. We totally agree, and we are huge advocates for home care workers having PPE during COVID, and I think Tracy can attest to that. We were one of the ones yelling from the treetops there, trying to make that happen. So we do think there is a need to make sure that we look at all pieces within the continuum of care to ensure that consumer health is met where people are looking for that care. I think just the main goal is to try and address the needs of the healthcare workers for safety and do so within the context of kind of the full picture of healthcare, so that we can try and meet consumer needs where they need to be met. And I appreciate the opportunity for being here today.
Thanks, Karen. Next, I see Julianne.
Good afternoon. I'm the section chief for community services at the Department of Mental Health and Addiction Services. DMIS operates programs and also funds many programs that provide mental health and substance use services. So throughout those programs, there's a lot of intersection and collaboration with home healthcare to provide services to people. So across these programs, some of them were already mentioned: assertive community treatment, community support programs, supported employment, mobile crisis teams, outreach and engagement. In terms of challenges, certainly the 24/7 response of mobile crisis is a challenge when it comes to safety. And I would also focus on the challenge of having two people all the time, two staff to go out. That's just not always possible currently. I look forward to sharing ideas from DMIS about healthcare safety and also helping to generate further ideas for safety of the workforce. Thank you.
So Julianne, just quickly, a lot of the programs that you mentioned, they're going into the homes as well. It's not just our home health providers. So I just want to help everybody understand that that's another level of worker that's going into the community. And with making visits with people, many times with serious persistent mental illness, correct? Yeah.
Correct.
Thanks, Julianne. Next, I have Honorable A. Groggins.
Hi, my name is Auden Groggins, and I am a Superior Court judge. I have been a Superior Court judge for almost 10 years, just a few months shy of 10 years. I have spent a majority of my time in the criminal courts. I'm currently presiding in the criminal geographical area court in the Ansonia Milford district. And I have also served in and presided over criminal courts in Hartford and Stamford. I was also spent some time in the juvenile courts for several years. Prior to my being appointed as a Superior Court judge, I was in private practice, and I practiced primarily criminal law. So I think that I have many years of criminal experience in the criminal justice system. I was also a legislator. I was a state representative in Bridgeport for approximately 6 years. And I did serve on the Public Health Committee for, I believe it was a year. I also served on judiciary for 4 or 5 years of that time. So I do have a legislative background as well. I anticipate that this group would be looking for me to share my knowledge of the criminal justice system and how the criminal courts work here in Connecticut, the superior courts, in terms of the process of the criminal justice system, from the arraignment, pretrial stages, and sentencing and probation of offenders, and also provide insight as to the factors considered by a criminal judge in terms of risk assessment and pretrial release, as well as those offenders when they are sentenced and put on either and serve a period of incarceration and then put on probation, or if they are just put on probation as part of their sentencing. I can certainly provide insight as to those factors that are considered, and including what role and factors criminal history plays in that process, and also in terms of setting bail and, again, conditions of pretrial release. And I also can provide, I know the judicial branch certainly would be willing, and I can arrange that to provide input and presentations from our people in court support services, as including our probation departments. You can hear directly from those, our experts and representatives in those areas. So I'm hoping that I'm not permitted to give legal advice, but I can certainly provide my experience and insight and my knowledge of the court system. And I hope to assist you in meeting your goals to protect healthcare workers and hospice workers and those clinicians, to keep them safe. So I'm happy to provide any information I can with regard to that.
Judge Grogan, are you also able to share information regarding the public-facing website of the judicial branch website that was written into the law that we're supposed to be checking?
Sure. I can definitely, and I can provide you you're talking about the technology and how it works, or the information?
Yeah, and if there's limitations, what we might, if there's anything we might be able to recommend on that side as well.
Absolutely, and I think that better than I would present you with the people who have developed, I hope,
Yeah.
that technology. Yes, I think
Perfect.
certainly we could get representatives to do that as well.
Thank you.
So thank you.
Thank you. Next is Ben Murphy.
Good afternoon. My name is Ben Murphy. I'm the Deputy Chief for the East Windsor Police Department. I've been serving up here for about a year now. East Windsor is a relatively rural community. Prior to that, I did 21 and a half years in the city of New Britain, which is more of an urban environment, much more diverse city from where I'm serving now. I missed our first meeting. I had contract negotiations, so I'm just trying to play a little catch up here, so I do apologize. I don't want to dogpile on some of the things we've heard, but from a law enforcement standpoint, some things that it said that I think would be incredibly beneficial for this discussion and the issue we have at hand. One of the first attendees said something about a repository of information. Everything we do in law enforcement is based on intel, whether we have it in-house in our CAD systems or we look from collect. I believe one of the nurses said, looking at a chart, something was flagged. We flag houses and addresses and offenders and, combative individuals all the time. That would be nothing but beneficial, and I think a necessity now for what we're facing, particularly with the topic at hand. Threat assessment and risk assessments. I know I see Sergeant Clark on here from Willimantic. Both of us served on SWAT teams for many years. We do a use of force matrix, a risk assessment, anytime we go serve something high risk. That should probably be something that's commonplace for this profession. Looking at what do we have for threats, mental health, substance abuse, weapons in the home. What is this person's background? Why are they on parole? All that should trigger certain, next moves. And the most important for us, I guess, from a law enforcement standpoint, is the communication aspect. We get called in when something's usually bad. A call ahead of time, we're going to see somebody who might be combative, who has a volatile background, who has made threats in the past. I can't always guarantee I have an officer available, but we should be able to work around that. Whereas if you have fears of safety and threats, having someone initially to come out to an address, we're never going to tell anybody no. And I guess going back, proactive is providing a level of training to the staff who goes out and sees that community. I firmly believe if you're going that, we don't like to teach kids about active shooter situations, yet we do lockdown drills because this type of stuff's happening in our culture. I don't want to teach a nurse how to defend him or herself and what cues to look for, but unfortunately, that's the reality we're facing. So I think just those 4 kind of talking points is what I had written down, and I'm more than happy to explore these as we move forward with this.
Thank you. Thanks, Ben. Next, we have Anna. You're on mute, Anna. I think, okay.
There we go. I work for the Department of Social Services. I do quality management for some of our HCBS programs. And I was also an in-home social worker for both the DCF, Department of Children and Families, and DSS, doing in-home assessments, and DCF for at-risk children that were in-home and placed out of home. So I have seen some of the risks. That's my intersect with HCBS. Some of the barriers that I see are, high crime neighborhoods, and that it's not always the member. Like we focus on the member being that high risk individual, but sometimes it's going into a large apartment complex where you're in an elevator or a stairwell and you encounter an individual that may mean you harm. It could be vehicle being broken into in a neighborhood where you commonly place your belongings in the trunk before you may go into a member's home. And then also that this unfortunately does not only impact home health agencies and access agencies. We have a lot of sister agencies like DDS, DMIS, DCF, and DSS that all go into the home and do assessments. And that a lot of the times when these referrals come in, the referrals come in from the patient, or the member. So if they're applying for a program directly, you may not have all the information. And you're going out into the home, or you may not know who's living in the home. So it could be somebody that's visiting as the high-risk person. It could be somebody living there. We've had people that have transient individuals coming in and out of the home. And we've also had people, our assessors, go into the home and find, weapons out in the open. Or they may find needles in the home or other things like that. I remember being on a case in New Haven and having to remove a child, and it took 3 hours to get a police officer out just so I could go into the home. I was also on another case that I had no idea I was going in and out of this home, and there was like an active FBI case on the home, and I had no idea what type of danger I was putting myself in just going in to see a child. So those are some of the things. I would love to see some sort of database that has maybe live data where you can go in and you can search an address, and maybe like Harriet Home Care can put in something where they saw, a client and had some sort of interaction, or some DCF went in, had an interaction, so what happened at that particular address. What I would like to see is just to see the goal to be just to enhance the workforce safety for all individuals that work and do in-home care.
Thanks, Anna. Sergeant Clark?
Good afternoon, everyone. I got it unmuted. Thank you for having me. This is great. As you all know, one of the most tragic ones that recently occurred happened here in Willimantic, actually on Chapman Street here in Willimantic. I'm Sergeant Clark from the Willimantic Police Department, administrative sergeant. I'm also on very many initiatives in town, the Task Force to Prevent Child Abuse and Neglect, a new member on the Board of Directors for Generations, and many other initiatives. So I'm in the community listening to a lot of the things, and there's been a lot of concerns and a lot of fears for healthcare workers in this community ever since this has happened. And I'll second what Deputy Chief Murphy has said. He's a great guy. I've known him for many years as well. So one of the things that I think is a big issue is, and I'll piggyback on the system to flag addresses. For specific houses here in Willimantic, for example, we don't even know some of the services that are taking place in the homes, such as persons on probation, etc. I think if we develop the system of tracking these things and a way for, like if things are flagged for healthcare workers to log in or log out, not to get into too many details, but I believe that for some of these instances, and maybe one of the most recent one that happened, it only took 8 minutes to deliver medications or something like that. Yet it wasn't until a lot later in the day where it was discovered that the healthcare worker didn't make it to several other meetings that she had had. So I think that maybe a system of tracking, if we do know that an address is flagged, and there's a plethora of other things that can be done, but I think, an immediate response, it only takes us in Willimantic, it's 4 square miles, less than 3 minutes to respond to a call. So maybe if we would have had some indication, or if other departments have indication that something, like she missed the next meeting or something, that might be helpful in start the process of law enforcement responding and investigating. So I do agree with the creating some kind of a system where not only do we know that some addresses are problem areas or should heighten alert, maybe requiring 2 persons, but also when does this person get there and when they leave. If they don't make it to the next meeting, that should be an immediate red flag as well. This is a community that I actually grew up in, so it's I do know many of the people that lived in the area that were raised concerns, that were frustrated with law enforcement because they didn't have any idea that maybe that kind of home was near theirs. So, it's on all levels, and I don't know, maybe something can be done about that, but I'm very happy to be here and assist in any manner I can.
Thanks, Sergeant Clark. Thank you. Next, we have Eric Smullen.
Hi, Sasa. Hi, everybody. Thanks for I've been really looking forward to having this opportunity to collaborate with all of you. I'll tell you what, since this rocked the home care world, and we've been dealing with all kinds of, just as I'm sure you all have, just threats, abuse, and some, in many cases, causing harm, both physical and emotional harm, from our workforce that are out in the community. And as I was talking to Tracy about a year ago, one of the things that I just struggle with is this lack of information sharing. Sergeant Clark, you just spoke a bit about it. There could be an incident in a building, a multi-unit building, and Sasa, you could have a client in that same building. Chris, you could have a client in that same building, and we have no way. And I could have had a critical incident around a patient's an employee safety issue that could have happened. It could have been a significant assault. Yet there can be no way that building gets flagged, because and that's a travesty. That as you continue to service the rest of the people in that building, it's up to our police to partner with us to make sure that there's got to be a stoplight, so that as we create risk assessments of different buildings or clients, that we also have the knowledge of what our law enforcement partners know. And I understand there's privacy in elements, but as we have to find a way that we can respect privacy, but also respect the safety of our workers that are getting deployed to the home. And so that, to me, from a Hartford Healthcare lens, we have many different levels of caregivers that are going into the home. It's not just the nursing and therapy from an agency perspective. It's our hospice workers. It's our private duty. But we also have physicians and APRNs that are deployed to the home. And so whatever we choose to recommend, my concern is that we come up with a way that is not that can be scaled for safety of care workers in people's homes, and that has a kind of broader application. Although obviously I don't want to lose our focus on execution. So that's anyway. Those are where my passions lie, and at some point, I believe that I have. Tracy, as work, and Sasa, as you're kind of collaborating about what stories might be the best stories to bring forth in testimony, I believe that I have some home care workers that have been through some things that they could add a really meaningful story, as well as we present some solutions. So I don't know what we'll decide to do, but I have my teams talking about what that would look like. So I appreciate everybody's collaboration.
Eric, thank you. Can you just remind everybody of your role at Hartford Healthcare? I know you mentioned Hartford Healthcare, but just
Yeah, I'm sorry. Yeah, Tracy, thank you for that. I'm the Senior Vice President that oversees our community network, which is all of our home care services. It's all the health services that are in the community. So my rehab services, the home care, the private pay home care, and our senior services. Home care is the largest portion of that. I would also say it's a little different, but I oversee the EMS services for Hartford Healthcare too. They are in the community and often in the people's homes. But that's why I bring this kind of this consistent theme of it's not nice. It's not nice right now. It's not safe. It doesn't feel safe to our colleagues. Thanks, Tracy.
Thanks, Eric. Next, we have Angel.
Good afternoon. Can you hear me?
Yes.
Angel Quiros, Commissioner of the Connecticut Department of Correction. My apologies for missing last week's meeting. I was out on sick leave. Just catching up and listening to the testimony before. Thank you to all the home nurses and hospice care workers out there providing the services. I'm responsible for 13 correctional facilities, over 500 nurses, so I do have a full understanding of the safety for our nurses. Mine is a little bit easier because it's inside 13 correctional institutions. But I also do supervise Director Gingras with the 4,000 individuals that we have out in the community under parole supervision. It is necessary for me to clarify that the Department of Correction only supervises individuals out in the community that are on parole status or voted to parole by the Board of Pardons. We do not supervise individuals on probation. We do have 3 hospice programs inside our correctional facilities. So the individual that is in need of a hospice care, we do not send out to the community. That individual will go to the 3 different sites that we have. And I think my goal is to collaborate with this committee to see what the Department of Correction can do to better enhance the communication when the cases come, when those individuals under our supervision are in need of home care. So thank you.
Thank you, Angel. I see Representative
McCarthy.
McCarthy.
Yeah.
Did you have anything that you wanted to add?
Well, so much.
Oh.
Thank you. I think we got everyone. Did I leave anyone? Is there anyone who didn't present as yet? Tracy, I think everyone went unless.
Yeah, I think so is true.
Perfect. Do you want to start section 4?
Yeah, so section 4 is really next steps. We've heard from so many of you, and I'm so glad to hear that there were a lot of common challenges, barriers that were shared, common goals that people are looking for, a database that's current. I loved hearing that over and over again. But I think what's even probably more important to our next steps is we had several of our home health and hospice providers come forward today with some general thoughts, but I think it's important to help all of you understand the vast variety of actual care that's provided in the community, whether it be through DCF or DMIS or Department of Public Health licensed agencies, DSS, et cetera. So Sasa and I were thinking that our next meeting could be more focused on helping you understand those details and also giving some case examples. We talked a lot today about mental illness. We talked about paroles and pardons. We talked about psych review board. Those are all kinds of cases that several of our providers will see in the community, and they work closely with those various departments. We also, Terry talked about the complex care, continuous nursing, which is a specialty in and of itself. Our hospice providers, our general medical, all those things. And I think it's important for you to have some actual examples of cases that have presented as risk and see if there's any questions, and then move forward with next steps. I think perhaps I think Sasa and I need to regroup and just make sure for each meeting thereafter, coming up with a repository or database, which we all seem to have a common thought on. We don't know how easy or hard that is. And that's why I asked Honorable Judge Grogans if she would be able to help us see, like the judicial branch website, the sex offender registry that's public facing, all those things, so people can see what we have to do now through the new law to try to make sure that we're gathering information and information that's accurate. So I think we're planning for our next meeting, which I believe we set up for, excuse me, I think it was the 16th, correct?
Yeah, I'm not sure we selected an exact date,
Okay.
but
Well, yeah, we looked to the 14th, but the 14th is Indigenous Day. So we were looking at either the Tuesday, the 15th or Wednesday, the 16th in the afternoon, 2:30 to 4:30. Does anybody have any strong feelings against or for either of those dates?
I think the last meeting we held the 15th, but
Yeah,
I'm not-
15th is what I had thought, yeah. Judge Grogans?
I will be out of the country on that
That's
date.
right.
Yeah, I can certainly, if you were addressing the issues you mentioned and you wanted them addressed on that date, could certainly see if our judicial department can help with that, but I won't be there. I'll be there certainly meetings after that, so it's up to you.
Okay.
Rep. McCarthy-Vahey.
Forgive me for being off camera, and Beverly or Peter may also reference this, but because of the number of working groups, we have 2 other working groups that are on Wednesdays. We had talked about the Tuesday, the 15th. So just for accessibility of the Zoom link and YouTube channel, if the Tuesday date works, that's probably more workable.
Okay.
And are we also looking at, we didn't want to do Monday, the 28th, because that is the 1-year anniversary of Joyce Grayson's death. So I think we talked about that following Tuesday as well, October 29th. So that people can keep that in their calendars. And then we'll try to do every 2 weeks from there forward on Mondays, as long as that works out. We'll map out a schedule and make sure everybody has it for their calendars. Anna, I see your hand up.
Yeah, the 15th, I'm also away. That's because that's the 14th is also usually a state holiday, and a lot of towns have it off. That's, typically a lot of people go on vacation that weekend.
Okay. Well, I think in an effort to move things forward, we will stick with the 15th, but we recognize that we do have these meetings all recorded, and Peter and Beverly from the Public Health Committee do send out the meeting summaries. So hopefully that will catch everybody up if they do end up missing a meeting. Does anybody have any questions or suggestions that we might have missed today?
Tracy, who's going to send out the Zooms, the invitation? Who do we look for it from?
Yeah, so Peter, Piotr
Okay.
Kolakowski, he is the admin for this work group.
Great. And right now we're looking on Tuesday, the 15th from 2:30 to 4:30. Is that correct?
Yes.
And then we're going to look at Tuesday, the 29th. Is that the next one, the same time?
Yes.
2:30 to 4:30?
Yes.
Okay, thank you.
Very good. Anybody else? Sasa, any closing remarks?
I believe this was a productive meeting. I'm super impressed with everyone and their understanding of our needs in the community. Oftentimes in home health, we believe we're out here on our own, and does anyone know what we're going through? I know now that we have a group of people that's truly aware of what we're going through and committed to helping us fix this problem. And I just keep thinking, we get the data, and after that, then what? But I know that's the meetings to come. You get the data, you know the risk. Now what? Now what do we do? But, I'm confident in this group. So thank you.
Thank you, everybody. Be on the lookout for more information.
Thank you. Take care.